Time is a funny thing in medicine. Some shifts feel like they last forever. You're checking your watch every few minutes, wondering if the clock is broken. Other shifts disappear in what feels like moments, a blur of trauma calls and critical decisions that leave you wondering where the day went. But sometimes time plays the cruelest trick of all. Sometimes it compresses 40 years of your life into 20 minutes, showing you exactly how much has changed and how much has stayed exactly the same. My name is Dr. Thomas Miller, and this is the story of my first day and my last day as an emergency physician, separated by 4 decades but connected by 20 minutes that will haunt me forever. First day, July 15th, 1982. I was 28 years old, fresh out of Northwestern Medical School, barely 3 weeks into my emergency medicine residency. I'd spent 4 years studying textbooks, practicing on simulators, and observing from the sidelines. Now, finally, I was going to be a real doctor. I remember everything about that morning. The way my scrubs felt stiff and new, still creased from the package. The weight of my stethoscope around my neck, heavier than it had seemed in medical school. The ID badge that read, Thomas Miller, MD. Letters I'd dreamed about for years but still couldn't quite believe were real. The emergency room at Chicago General was exactly what I'd expected and nothing like I'd imagined. The chaos was overwhelming. Phones ringing, monitors beeping, staff moving with purpose I couldn't yet decode. I stood in the doorway for a moment, paralyzed by the realization that people's lives would soon depend on my decisions. Dr. Miller? A voice behind me snapped me back to reality. I'm Dr. Sarah Patterson, you're attending. Ready to save some lives? Dr. Patterson was everything I hoped to become. Confident, competent, unflappable. She'd been working emergency medicine for 15 years, back when it was still a new specialty, and she commanded respect from everyone in the department. Absolutely, I said, trying to inject more confidence into my voice than I felt. Good, because it's going to be a busy day. Let's start with something simple. Simple. In emergency medicine, I would learn nothing is ever simple. My first patient was Mrs. Eleanor Williams, 73 years old, brought in by her daughter for feeling dizzy. In 1982, our diagnostic capabilities were limited compared to what would come later. No CT scans, no advanced cardiac monitors, no point-of-care ultrasound. We had X-rays, basic blood work, and our clinical skills. What seems to be the problem today, Mrs. Williams? I asked, sitting beside her bed and opening a paper chart. No computers, no electronic records, just handwritten notes on actual paper. I've been feeling lightheaded for 2 days, she said. My daughter thinks I should be checked out. I took her vital signs manually, blood pressure with an analog cuff, pulse by counting at her wrist for a full minute, temperature with a mercury thermometer. Her blood pressure was 80/50, significantly low for someone her age. Dr. Patterson, I called nervously. Could you take a look at this? Dr. Patterson reviewed my examination, asked Mrs. Williams a few more questions, and ordered an EKG. The machine was the size of a small refrigerator, printing results on paper that we had to interpret by hand. Inferior wall MI, Dr. Patterson said quietly, pointing to the changes on the EKG. She's having a heart attack, silent presentation, not uncommon in elderly women. In 1982, treatment for heart attacks was limited. We gave nitroglycerin, morphine for pain, and oxygen. No emergency cardiac catheterization, no clot-busting drugs, no stents. We did our best and hoped for the best. Mrs. Williams was transferred to the coronary care unit, where she would either recover or not. That was the reality of 1982 medicine. We treated symptoms, managed complications, and accepted that some battles couldn't be won. But she survived. 6 weeks later, she sent me a thank you card with a picture of her garden. Thank you for caring about an old lady's dizziness, she wrote. It was the first letter from a patient I'd ever received, and I kept it in my locker for the rest of my residency. That first day ended at 7 p.m. after 12 hours that felt like 36. I'd seen 15 patients, diagnosed everything from appendicitis to anxiety, and learned that medical school had prepared me for the science of medicine, but not the art of it. As I drove home to my small apartment, still wearing scrubs that now felt broken in, I called my parents from a payphone to tell them about my first day as a doctor. My father, a Vietnam veteran who'd seen his share of medical care, simply said, "I'm proud of you, son." I fell asleep that night, exhausted but exhilarated, knowing I'd found my calling. Last day, June 30th, 2022. 40 years later, I stood in the same emergency room, now completely transformed. Electronic monitors displayed vital signs in real time. CT scanners provided detailed images within minutes. Ultrasound machines the size of laptops gave us instant information about internal organs. The paper charts had been replaced by computer terminals, the analog equipment by digital precision. But the chaos was the same. Phones still rang, monitors still beeped, and staff still moved with purpose, though now that purpose was guided by protocols and algorithms that hadn't existed in 1982. I was 68 years old, 3 days from retirement, and feeling every year of those 4 decades. My back ached from 40 years of leaning over patients, my hands were stiff from arthritis, and I needed reading glasses to see the computer screens that had replaced those paper charts. Dr. Miller called Maria Santos, our head nurse. "We have a trauma coming in. ETA 5 minutes." Maria had worked with me for 20 years. She'd seen me evolve from a confident young attending to whatever I'd become. Hopefully wiser, definitely more tired. "What do we know?" I asked, pulling on fresh gloves that now came from a dispenser on the wall instead of a box on a cart. 73-year-old female, found down at home, altered mental status, possible overdose. 73 years old, the same age Mrs. Williams had been on my first day. But this case would be different in ways that would have been unimaginable in 1982. The patient arrived unconscious, brought by paramedics who'd already established an IV, monitored her cardiac rhythm, and checked her blood sugar with a portable glucometer. In 1982, none of those capabilities existed in the field. "What's her name?" I asked the paramedic. "Jennifer Martinez, found by her son with an empty pill bottle beside her. Appears to be intentional overdose." An intentional overdose. In 1982, we saw overdoses, but they were usually accidental or related to street drugs. The opioid epidemic that would define my later career was still years away. "Jennifer, can you hear me?" I called, checking her pupils with a penlight. They were pinpoint, classic sign of opioid overdose. Her son, Michael, stood in the corner, wringing his hands. "Doctor, she's been in pain for months. Ever since my father died, she's been taking more and more pills. I tried to help, but..." I nodded, understanding immediately. This was a story I'd heard hundreds of times in the last decade. Chronic pain, overprescribed opioids, tolerance, dependence, desperation. "How many pills did she take?" I asked. "The bottle was almost full yesterday. It's empty now." I calculated quickly. If the bottle contained a month's supply of opioid pain medication, Jennifer had taken potentially 30 times her prescribed dose. In 1982, we would have pumped her stomach, given supportive care, and hoped. In 2022, we had naloxone, Narcan, a medication that could reverse opioid overdoses within minutes. 2 milligrams Narcan 4, I ordered, and let's get a full tox screen. The transformation was almost immediate. Jennifer's breathing improved, her pupils began to respond, and within 5 minutes, she was conscious and talking. "Why?" she asked when she realized where she was. "Why didn't you let me go?" It was a question that would have been unthinkable on my first day. In 1982, patients were grateful to be saved. By 2022, some patients resented it. "Jennifer, you're in pain," I said, sitting beside her bed. "Physical pain, emotional pain, but we can help with both. You don't have to suffer alone." What followed was a conversation about addiction treatment, mental health resources, and chronic pain management, all specialties that had evolved dramatically during my career. In 1982, addiction was seen as a moral failing. By 2022, we understood it as a disease. Jennifer was admitted to our addiction treatment program, connected with grief counseling, and started on a pain management protocol that addressed her chronic issues without relying solely on opioids. 3 weeks later, she sent me a letter, not a handwritten card like Mrs. Williams, but an email through the hospital's patient portal. "Thank you for seeing me as a person, not just an addict," she wrote. "You saved my life." The 20 minutes. My shift was ending at 7 p.m. exactly as it had 40 years earlier. As I sat at a computer terminal typing my final notes, something extraordinary happened. Eleanor Williams walked into the ER, not the 73-year-old woman I'd treated in 1982, but her great-granddaughter, also named Eleanor, also 73 years old, also brought in by family for feeling dizzy. The similarity was uncanny. Same name, same age, same chief complaint. But this Eleanor lived in a different world than her namesake. "She's been having episodes of dizziness for 2 days," her granddaughter explained. "We're worried about her heart. I performed the same assessment I'd done 40 years earlier, but now with tools that would have been science fiction in 1982. Her EKG was transmitted wirelessly to a cardiologist who read it within minutes. Her blood work was analyzed by machines that gave results in real time. A bedside ultrasound revealed her heart function instantly. The diagnosis was the same: inferior wall myocardial infarction, but the treatment was revolutionary. "Eleanor," I said, "you're having a heart attack, but we can fix this." In 1982, those words would have been false hope. In 2022, they were medical fact. Within 20 minutes, the same 20 minutes it had taken me to diagnose Mrs. Williams in 1982, Eleanor was in the cardiac catheterization lab, having the blocked artery opened and a stent placed. The procedure that didn't exist during my first day would save her life on my last day. As I watched Eleanor's EKG return to normal in real time, I realized something profound. The 20 minutes between her diagnosis and treatment represented not just the span of this emergency, but the span of my entire career. In 1982, I'd been helpless to do more than treat symptoms. In 2022, I could literally watch a heart being repaired on a monitor. The technology had advanced by decades, but the fundamental drive to heal remained exactly the same. The reflection. That night, as I cleaned out my locker for the last time, I found Mrs. Eleanor Williams's thank you card from 1980, but some things hadn't changed at all. The fear in a patient's eyes when they thought they were dying, exactly the same. The gratitude of families when you saved someone they loved, identical across 4 decades. The weight of responsibility that comes with other people's lives in your hands, heavier now than ever. The satisfaction of making the right diagnosis, giving the right treatment, seeing someone recover, absolutely unchanged. On my first day, I thought medicine was about knowledge, knowing the right diagnosis, prescribing the right medication, performing the right procedure. By my last day, I'd learned that medicine is about connection, seeing patients as people, understanding their fears, and being present in their most vulnerable moments. The technology that distinguished my last day from my first was remarkable, but it wasn't what made me a better doctor. What made me better was 40 years of learning to listen, to empathize, to see beyond the symptoms to the human being experiencing them. Jennifer Martinez didn't need just naloxone to reverse her overdose. She needed someone to understand her pain and help her find a way to bear it. Eleanor Williams didn't need just a stent to open her artery. She needed reassurance that she would see her great-grandchildren grow up. Both Eleanors sent me thank you notes. Mrs. Williams thanked me for caring about an old lady's dizziness. The younger Eleanor thanked me for making me feel safe when I was scared. 40 years of medicine, and the thank you note said exactly the same thing. Thank you for caring, thank you for being present, thank you for treating me like a human being. As I walked out of Chicago General for the last time past the emergency room where I'd spent 40 years of my life, I realized that my first day and my last day were not really separated by 4 decades of change. They were connected by the timeless constants of human suffering and healing, fear and hope, illness and recovery. The 20 minutes it took to save Eleanor Williams in 2022 represented 40 years of medical advancement. But the moment she opened her eyes and said, "Thank you," that was the same moment I'd experienced with Mrs. Williams in 1982, unchanged by time or technology. Medicine evolves. Doctors, if they're lucky, learn to become more human. Today I'm retired sitting in my Florida home, but I still have both thank you notes on my desk. 40 years apart, they remind me of something important. The purpose of medicine isn't to master technology or perfect procedures. It is to be present with people in their most vulnerable moments and to offer whatever healing we can provide. Sometimes that healing comes from a stent placed in 20 minutes. Sometimes it comes from holding someone's hand while they're afraid. Both matter. Both are medicine. Both are why I became a doctor.